Hey guys, this is Dr. Shivam and we are going to discuss the new pattern clinical based questions. Let us see this question where we have a 57-year-old woman who is 2 day post left modified radical neck dissection. That means she is a post operative patient day 2 of radical neck dissection, modified radical neck dissection type 3. Routine review reveals a drainage output of 700 ml per 24 hour and drain contents have a creamy white appearance. Now you have been given in the question a drain output which is creamy and is collected after neck dissection. Let us see what the examiner wants to know and why this collection is creamy. So what is the likely diagnosis? How would this be confirmed? And some more question. Now the first thing that should come to your mind is why this collection is getting creamy. So yes, this is a case of chyle leak that has been caused while doing modified radical neck dissection. So it is one of the complication of modified radical neck dissection where intraoperative injury to the thoracic duct occurs and results in chyle leak and chyle collection in the drain output. The characteristic is creamy white appearance in drain output. So if you get a drain output like this in your question, you should suspect a chyle leak after neck dissection. This complication is detected post-operatively by unexpectedly high drain output, sudden increase in drain output, and when having creamy or basically a fat diet, establishing oral intake with creamy or milk tea colored fluid in the drain bottle or tubing. Now when it is said low output and when it is said high output, so low output is collection less than 500 ml within 24 hour and high output is greater than 1 liter per 24 hour. What investigations you can do to confirm? So you can send the drain output for triglyceride analysis. So triglyceride level of greater than 100 ml milligram per dl or level greater than that is diagnostic of chyle leak, right? Now our fourth question was what is the management? So first of all, the first preferred management is conservative therapy. So you would do a conservative therapy especially for the low output leaks, and what you need to do is you need to advise the patient for bed rest, leave the drain in situ, see how much collection is getting. You need to see for nutrition where you will be giving the patient modified fat free or medium chain triglyceride diet. So this is very important. In option you can be asked what will be the management, so in that this can be one of the option, modified fat free or medium chain triglyceride diet. TPN, that is total parenteral nutrition, is widely used, but there is no consensus as such. Now, some medical therapies like octreotide and orlistat have been tried. Skincare, like as chyle is irritant to skin, you would have to do regular dressing to look for the wound breakdown. You have to monitor for electrolyte loss because with chyle electrolytes are getting lost. And the next thing is if it doesn't stop even after conservative therapy, you have to manage the patient surgically. Now there are different methods, like locally you can re-explore the neck to ligate the leak site, but this is usually done or indicated within 24 hours, as beyond that tissue will be excessively chylous contamination leading to inflammatory reaction. Distal surgical steps are like thoracic duct embolization and endoscopic or thoracoscopic ligation of thoracic duct. So these are some of the rare surgeries that are being done. Mostly it is stopped with the conservative therapy. Now if you want to see more of these clinical scenarios, you can download our free app, that is Medex, and just ping me on my WhatsApp number that is given below in the description. You will be getting some important updates and topics that you should know for your examination purpose, especially NEET PG and INI-CT. Coming to our second question, a 67-year-old gentleman presented with multiple malignant nodes arising from tonsillar carcinoma. You have been given this operative picture, that is intraoperative picture, and they are asking what is the procedure that is being carried out in the picture. So one thing is clear, patient is having tonsillar carcinoma with multiple neck nodes. So this is something related with the neck and clearance of these malignant neck nodes. So this is basically a neck dissection being done. How is this procedure classified? What are the complications and TNM classification? Now I have already made a detailed video about the neck dissection, types of neck dissection, and the TNM classification. So we'll just have an overview very fast so that this video also doesn't get much prolonged. So this is basically a neck dissection, and there are different types of neck dissection like radical, modified radical, selective and extended radical. So in selective neck dissection, there are different types further like supraomohyoid neck dissection, lateral, posterolateral and anterior compartment. Supraomohyoid is very important. Again, a question of your NBE type. Level 1 to 3 is dissected. Lateral is 2 to 4, that is 2, 3, 4. Posterolateral is 2, 3, 4, 5, and anterior compartment mostly done for thyroid and some laryngeal malignancy is level 6 plus minus 7. So very important for you to know selective neck dissection. And in modified neck dissection we have three types. So you all know there are MRND type 1, type 2 and type 3. In type 1 we preserve spinal accessory nerve. In type 2 we preserve both spinal accessory and IJV, and in type 3 we are preserving all the three vital structure, that is spinal accessory, internal jugular vein and sternocleidomastoid. So this is also called functional neck dissection, right? And coming to our last thing, that is radical neck dissection. It is removal of all the three vital structures, that is IJV, spinal accessory, sternocleidomastoid, lymph node of level 1 to 5 and submandibular gland, right? So this was little about neck dissection, and if you further prolong this, like if you remove more than this whatever you have removed in radical neck dissection, it will be an extended radical neck dissection if you are removing any other lymph nodes or any other non-lymphoidal structures. Complications are very easy, like any other surgery. It will be hemorrhage, infection, skin flap necrosis, injury to the spinal accessory nerve, to the vagus, marginal, mandibular, lingual, chyle leak we have just seen, cerebral edema, carotid artery rupture, recurrence like nodal recurrences, chronic neck pain or shoulder pain, and carotid artery rupture, which is very rare but very dangerous. Now one thing, you have your INI-CET very near, so I would expect you to have that confidence in you that yes, you will be able to make it through the exam. So don't consider yourself inferior to anybody and don't have fear of this INI-CET. It is take this exam just as any other exam that you give, like a mock, and you will see that you are being able to perform much better. So have patience and have that confidence in you that yes, you will be able to do it and you will do it, right? So this is Dr. Shivam. Stay happy and do write me back how these are helping you and what more we can do to help you at this moment. Stay happy and stay healthy.